today to be your MC, meaning that I am the master of everybody that is seated here. Well, I only say that looking at those in front, but I'm not looking at those by my side, because they are my masters. We are very happy to have all of you here. Just some few protocols for the occasion. We have people that are joining us online, and of course big people, principal people, and so all speakers, we would kindly request that you come to this podium and speak from the podium if you wouldn't mind. If it's difficult for you, we can understand, we'll see how best to get the podium to you. That is one, and the other is that we should please ensure that our phones either are off or are in silence. So charity begins at home. I hope I got that right. So that we don't interrupt. We should also ensure that we limit as much as possible the movement of people in and out while the discussions and the speeches, the lecture is going on. We would also implore the ushers, please, to ensure that the noise that is coming from the back is limited as much as possible. This is really heavy load to carry. I don't think I wish anybody to carry this load I'm carrying. So for the benefit of everyone and for the interest of all those that are speaking, kindly permit me to officially recognize first the Honorable Minister of Health, Dr. Ahmadulamin Samate, who is present with us virtually and who hopefully, thanks to technology, will be hearing his voice. I want to recognize the Honorable Minister of Higher Education, Science and Technology, ably represented here by Mr. James Gomez. I want to recognize the Vice Chancellor of the University of the Gambia, Professor Herbert Robinson. I also want to recognize the Chief Medical Director of Edward Francis Small Teaching Hospital, Dr. Amar Al-Jafari. I want to recognize the Provost of the School of Medicine and Allied Health Sciences, ably represented by Professor Tinu. I want to recognize the Chairperson of the LOC, Dr. Abubakar Jah. We recognize our keynote speaker, Dr. Niyi Ade Ajayi. We also recognize him and the team that came with him from King's College and Evelina Hospital, and for a great job they have done through the outreach. I want to recognize Dr. Charles Fowlis with the Eurolink team that have also come and have done a very great job during this period. I want to also recognize some visiting scholars with us, my own boss, Professor Yusufa Saho from Dakar, who is always at our doorsteps whenever he's needed. I recognize the Registrar of the Medical and Dental Council, Dr. Kabir Chan, whose capacity today is a junior house officer, and I'm very happy to call him junior house officer. You are most welcome, Dr. Chan. I also want to recognize the chair and all the team members of the local organizing committee, the chair and all the team members of the scientific committee of this conference, the chair and all the team members of the fundraising committee. Can we please have some, can the ushers please get the noise under control? The chair and team of the welfare and logistics committee, the chair and team of the fundraising committee, the chair and team of the outreach committee, the chief matron and all departmental matrons of Edward Francis Small Teaching Hospital, and all other hospitals that are here present were highly recognized. Heads of departments of Edward Francis Small Teaching Hospital and units, and all other hospitals also here present. The PRO of the hospital, the Director of Finance of the hospital, professors of the Edward Francis Small Teaching Hospital and the University of the Gambia, senior consultants, senior registrars, medical officers, house officers, nurses here present, medical students, other student nurses and other students here present, invited guests, the press, distinguished ladies and gentlemen, all other protocol duly observed. And I can give permission as chair or as MC to those in the high table. You can omit all these names. You have already said them because it's going to take another 1 hour again for you to call all this. I want to, as I was saying, I saw somebody just walk in, the Deputy Chief Medical Director, who is also the Chairman for MAC, Dr. Jan. You're most welcome. On my behalf, on behalf of the LOC, I want to heartily welcome all of you to this very important occasion, the occasion of the first or maiden Banjul International Scientific Conference. Conferences or scientific conferences are aimed at one thing: experts to come together and exchange and share and educate each other on the new trends in their scientific or medical world. And that is what we are about to witness. I want to say a big thank you to all those who have worked tirelessly to make this thing happen. And today, as we start this occasion, I would want to start, of course, by us standing up and taking the national anthem. Shall we please rise? We talked about it. We said, oh, we want to have an international conference. So that was it. That's it. It's so difficult to get things started. Well, we wanted to have it last year, it didn't work. This year also we wanted to have it, it didn't work. Then came something. And luckily, at some point in time, the Chief Medical Director now, Dr. Amar Jafari, kept on saying that, look, I want an international scientific conference. I went to his office, I remember 2-3 times he said that to me. Dr. Ja also went to his office, I remember a few times also he said the same thing to him. And one day, as God would have it, we all met at the office. And he was like, look, I want an international scientific conference. And we said, well, we've been talking about it, but just putting things together and make it work, that's the problem. Then, the good things start to happen. And Dr. Ja said, yes. In fact, we have our international colleagues that are coming. Oh, when are they coming? I think they're coming in May. Okay. Okay, Java also was telling us, yes, oh, my Evelina team is also coming. When are they coming? Oh, they're going to be in May. All right. Then Dr. Java proposed, why not we capitalize on that and organize an international scientific conference? Then you don't need to get people go and come again. They are all coming. And we all said, okay, that's fine. All right? So then I called Dr. Ja, who is my boss, but in the Department of Surgery, I can call him. Let me just stop that way, yes? So I called Dr. Ja, and I'm like, Chief, please, you lead that thing. He said, no. I said no, because if I want to take it, I wouldn't do it. Kindly lead it. And Dr. Ja accepted. And Dr. Ja took the lead. And since that day, and we had a very short time. This was discussed 3 months. Because we were capitalizing on the fact that we're going to have the guests coming. Then the teams were formed. You can't imagine how amazing these young people are. Everybody took his role so well. And I want to apologize. That's one of the reasons why a lot of things happened a little bit late. Abstract book was late. So many things were late. But I can assure you, this is just the first one. BISSC and all the people seated, the next one, you will get it prepared long before, and we are actually ready for that. So please kindly give a big round of applause to all these people that have made it happen. Having said that, I have all the honor to invite Dr. Abubakar Jah, the chairperson of the LOC, to please come and give his statement.
Used to being in the theater and operating on the head and the spines, but taking the role of Master of Ceremony can be very daunting, and we're very proud and happy to have him to take that role. I will still repeat some of the names that he has said, because this is a very historic moment. This is history in the making in the Gambia. The Honorable Minister of Health, who is today with us only virtually because he's out of town, but cannot miss such an important event, which he supported from the word go. The Minister of Higher Education, represented by the Director of Research of UTG, Mr. Gomez. The Permanent Secretary of Ministry of Health, Mr. Jete, who is somewhere in the crowd, I suppose. The Vice Chancellor of the University of the Gambia, Professor Herbert Robinson. The Provost of UTG, my good friend Professor Ogun, ably represented here by Professor Tinu. The Chief Medical Director and one of the initiators of this conference, Professor Amar Jafari. The representative of the WHO, Dr. Desta Tiruni. The representative of UNFPA, Rose Sar. The coordinator of the postgraduate medical training in the Gambia, Professor Kasama. The registrar of the Medical Council of the Gambia, and I must say here, one of the icons of discipline in the medical practice, whose strength and resilience and persistence in his goal I admire and strive to emulate, Dr. Kabir Cham, but he has recently dubbed me as the strong-headed, which I think he got from my wife. The President of the Medical and Dental Association of the Gambia, Dr. Lamin Jete, and through him, all my senior colleagues, and unfortunately that number is dwindling, and my contemporary colleagues. I'm very happy to see that for now that is constant, and I hope it remains like that. And my junior colleagues, who are increasing in number, and I am hoping it continues to increase in number. My colleagues from the United Kingdom and other countries here present, including Professor Nie. My mentor and good friend and confidant in urology, Dr. George Akindele Fowlis. We are taught to respect our teachers in the medical field, and in Dr. Fowlis, I don't find that difficult to do. I have actually been accused of being the first urologist in the Gambia, but I must say I'm innocent of that allegation. It's probably is Dr. Fowlis, the first urologist in the Gambia. The only thing I am guilty of is being the first one to come to the Gambia to practice and to delve into the waterworks of Gambian men. My other colleagues, non-doctors in the medical field, nurses, pharmacists, physiotherapists, laboratory scientists, radiology technicians, etc. Medical students who are a very important part of this today. Our major sponsors. As I said, this is history in the making, and this came on an impulse. And Dr. Jabang has said that it is 3 months, but it's not actually 3 months. It is less than 3 months. It's about just less than 8 weeks when we started this idea. So it was really a very tight schedule. And I cannot thank the LOC enough. It's a teamwork, and every member of that team has done so well for us to be here today and see this level of organization. So our major sponsors, starting with Africell, Kairaba Pharmacy Group, the Q Group Foundation, Dr. Jawara of Gach Companies. All of these people I have mentioned have donated hundreds of thousands of dollars towards this. They are our major sponsors, and all within a very short time. We just went to their offices and the checks were signed. I would also want to recognize WHO, who sponsored the whole of the abstract book and the printing of the abstract book. UNFPA, who sponsored most of the print materials that we have today. Some other sponsors like the Sharab Clinic or Hospital, MK Clinic, Dr. Jafari, the CMD, who apart from all the hard work he has done personally, donated a quite handsome amount of money from his pocket. The media here present and all other protocols respectfully observed. I welcome you all to this maiden Banjul International Surgical Scientific Conference. As Dr. Jabang said, it is a dream come true for many of us in the medical community. Medical conferences are means for continuous medical education and research for the community. Exchange of ideas, sharing of experiences and new techniques and knowledge. Attending such conferences equips practitioners to serve their communities better and their countries better. And the benefits are enormous. And that is why countries all over the world fight to take the hosting of such conferences. And if you go elsewhere, companies actually approach such organizations rather than the organization approaching them to put their money in it so that they can also reap some of these benefits. This is history in the making, and therefore it is good to talk about the history of how all this came about. And I'm happy that Dr. Jabang has alluded to it. I remember when the Chief Medical Director took office, I went to visit him personally as a courtesy visit, just to discuss issues. And in his typical way, all of you who interact with him, you know how the CMD usually speaks. Dr. Ja, how can you help me to organize a conference, to invite experts all over the world, so that we can put the name of Gambia in the map of the world? I want that to happen. And I told him, okay, I will think about it. And we shelved the idea. Just like Dr. Jabang said, all of us have thought about such things in the past, but it is always shelved. So this idea was shelved until Dr. Fowlis actually wrote to me an email and said, Dr. Ja, we are planning to come as the usual Eurolink visit. Those of you who know Eurolink is the group that introduced me to urology myself. So this year we're coming back for the usual visit. I was already at that time working with the Spanish team, who was also supposed to come at this time. We were also working with a Canadian team who was working in Serekunda Hospital. And I knew that Dr. Cherno Jallo was also working with the King's College team, who were coming around the same time. So the idea popped up then. This is the right time to do the conference. It was barely 2 months ago. I promptly spent a sleepless night that night, I remember, and made the concept note. And went to the CMD's office the next morning and gave him the concept note and say, we can do this conference. And we called our colleagues, just like Dr. Jabang has said, and it was an easy takeoff because every one of them, every one of us wanted to make this happen. And since then, the teamwork has been amazing. Some of us are not new to organizing conferences in the Gambia. I was involved, together with Dr. Fowlis, together with Dr. Roberts here, in organizing the first urology, that was only urology, conference, which was attended by the Eurolink and largely sponsored by the Eurolink, but we had lots of Gambian sponsors also. And that was a very big success. And that was the first time, I think, that some of our colleagues here in 2011 who were just graduating and are now consultants, but they were just graduating, or some of them were still medical students, had the chance to present in a conference of that nature. We also have hosted the West African College of Surgeons meetings, some of us at least twice during our time, and it was not difficult to start things. So we called all the heads of department. I don't want to take too much time to name everybody, but we must name some of the main ones that were there in the meeting. Dr. Roberts, again, Dr. Jabang, Dr. Keba Marena, Dr. Keita, obstetric and gynae. We had the likes of, anytime you start mentioning names, you forget people, so I'm really sorry that I'm mentioning some names. I'm sure I'll forget some of them, but it's not because they have contributed less. It is just because the gray hair is coming and I am losing some of my memory. We had some other members like the Dr. Firas of MK Clinic, Dr. Lamin Jete, who is the chair of the scientific committee. For such a conference, none of us has done anything. The main work actually is the scientific committee. This is nothing, this is just an opener. It is later during the day that we are going to have the real work done, and it is his committee that has done all the donkey work to make sure that we have a proper scientific meeting here. Some of our colleagues, that Dr. Babakar saw in the urology department, Dr. Kajali Kamara, who has spent sleepless nights over these nights to make sure that this thing happens as the secretary of the LOC. Dr. Neneba, who is the welfare. You can only imagine 6 weeks doing all this, making sure all this is in place, which is not an easy feat at all. As part of the activities is the outreach, and that has been going on for the past 1 or even more than 1 week now. And there are lots of very important surgeries that have already been done with the visiting team working with our local surgeons. The benefits of such a conference are immeasurable. I told all our donors, if you donate $600,000, it may sound a lot, but what we're going to get out of it is much more. Some of the operations we have done so far, one operation alone, if you go to the UK, those who are working in the UK know, might cost up to £20,000 for one operation alone. You can do the mathematics. You know, if you've done 40 or 50 of those, how much you have gained. That apart from the knowledge that we're going to share in these next 2 days with each other. So it's a great benefit. I am therefore calling on all to put April next year, it's going to be April next year, we've decided already, in your diary. Attend the conference and represent the conference for medical personnel. For the sponsors, to put it in your diary and say that I want to be one of the top sponsors of this program, because it's going to save lives, not only during the conference, but even beyond that, because it makes us all better surgeons. And we're going to operate better, and we're going to save lives better after this exchanging such ideas. I want you to do it in such a way that Dr. Jallo doesn't have to get out of his theater during the time that we're raising funds. Dr. Jallo is one of those surgeons, we have many of them in the Gambia, who are addicted to the theater. They can never get out of the theater, just operating. And taking them out of the theater so that they can raise funds, we can forgive them that. We can allow them to operate and save lives. So next year, I am hoping that we don't have to struggle so much to raise the amount that we want to raise. The theme this year is developing minimally invasive surgery, and sub-theme is about surgical infection reduction. These are very important aspects of medicine, and that is coming up in the Gambia now. There was a time when it was a dream just to talk about minimally invasive surgery, laparoscopy, endoscopic surgery, but now it is coming up very well in the country. I don't want to extend this any further. I hope I have not gone beyond my 10 minutes, because the master will tell me. But I'm going to try to stop here and resist talking about a lot of other things. And I wish all participants today a very successful, very fruitful deliberations over the next 2 days. And once again, I thank all the dignitaries for leaving their time to attend with us here. And I thank all our sponsors for making this possible today. Thank you and have a good day.
We can thank the people that have really worked and had tireless nights. The Secretary Dr. Jah made mention. Well, you know, when Dr. Jah was making mention of the CMD, I was actually thinking, he seems to be talking about the CMD. Dr. Jah, have you had a lot of interactions with the CMD? How many of you have a lot of interactions with the CMD? You will say the way Dr. Jah said, Yani Dr. Jah, Yani, well, I want to have an international surgical conference. That's how you will say it. And indeed, yes, today it has come to be. So thank you so much. We will proceed as we invite.
Thank you, Dr. Jamal, Head of Department and the best MC. Maybe if there is any celebration in any part in Gambia, maybe you will join them. Today I am very happy, so let me break the protocol. I will talk directly. I will say good morning, Office of the First Lady and the Foundation, FAB Foundation for the support. Good morning to my boss, and he is my boss, our Honorable Minister of Health for his support. Good morning to the Minister of Higher Education and the Director of the Research. Good morning to the University of Gambia. Good morning to the Vice Chancellor and to the Medical School, the Provost, Prof. Ogen and the Prof. Tinu. Good morning to our Medical and Dental Council, Dr. Kabir Sham. Good morning to our guest, international guest. Good morning, Deputy Chief Medical Director, Dr. Jang. Good morning, former Deputy Chief Medical Director, Dr. Roberts. Professor Saho, special bonjour and good morning for you, and you're welcome. But I'm sorry to tell you that very soon, no patient will go to Dakar to do operation. So I'm very sorry. From now, all the operation will have done in Edward Francis, inshallah. So forgive me for that, but you're welcome. Good morning, all my colleagues, all our guests. I am very happy really today. I feel that like I celebrate with my child the first birthday celebration today. This conference, I dreamed about this conference since I came to Gambia 2013. 10 years now, and I put it, why not Gambia can host a conference? Gambia is not less than any other country. We can host a conference. Since 2013, and this is a dream in my mind, and now because all of you, the dream become true. This conference put the name of the Gambia and Banjul. Maybe we cannot do it this year, but next year, everybody will know about Banjul International Surgical Scientific Conference, inshallah. We can do, this conference help us with two issues. First of all, to increase the skills of our doctors by attend this presentation and to do operation. Our waiting list is too long and everybody knows. So this conference help us about that. So really I am very happy. I am very grateful for all the teams. Really 8 weeks. We organized all the team, 8 weeks we organized, and we came today with this celebration. So thank you for everybody. Let me start. I want to say thank you, Dr. Jah, because if I don't have Dr. Jah in the hospital, no conference today, to be honest with you. So big thanks, Dr. Jah, really for your support. Dr. John Jaban, the head of department, and all his team. Professor Keba Marina, I don't know why he is not always happy from me, but good morning. All my colleagues and who participate in this conference, all the committees, Dr. Chernojalo, Dr. Lamin Jaite, Dr. Neneba, Dr. Gassama, and of course, all of them, really they're doing a great job in this issue. Also our partner, we don't forget that we have good partner for the first time. We engaged the private hospital with the government hospital. So big thanks to MK Clinic, Dr. Firas, thank you so much. And big thanks to Sharab Hospital. Really, this partnership helped us. Now, if you know that we do operation in Sharab and in MK Clinic, and we use Kennefic Hospital. So if you count these theater rooms, you will find maybe more than 10 rooms. All of them work very hard. The problem in Gambia, nobody knows what we are doing on the ground. Really, we try to do our best. We try to do everything for Gambia and the patient. If you always, I say, when you work in health sector, no any excuse. You need to succeed because always patient life in your neck. We are responsible about patient life. No excuse about no money. No excuse that no funding. We need to do something. We need to try to do something for the patient. So really, today is a special day for me. Thank you for all of you to attend this conference. Really, we need to serve. I promise you, next year, inshallah, maybe you will see more partners and more people attend. And before I end, really, we need to thank the sponsors. We need to thank AfriCell. We need to thank Tube Group. We need to thank Keraba Pharmacy. We need to thank also Dr. Jawara for the support. And we need to thank Mr. Hamido Jah Oil. You know, Jah Oil always support. Maybe he is busy and not in the town, but he promised to come and visit me on next week, and I think he will donate something. So this message from here to Hamido Jah, I'm waiting for you. Monday I am free if you have time. Between 10 and the 12th, I am waiting Mr. Hamido Jah Oil. Until now, we didn't pay for the hotel. Please, there is some balance. Maybe if you can help. Thank you, everybody, and welcome.
Dr. Jah sent a message on the page when the days were getting close, and he was like, "Look, all clinical heads and all surgeons whatsoever, please, there is not going to be any clinical work for you. Just this is from all the clinical work, and then let's come and concentrate because time was going. There was no money that was coming on." And we were supposed to pay for this place, and it was going to be expensive. We were supposed to print everything, and so that was that. So we all said yes, thumbs up, yes, we all agreed. Then Dr. Jafari came. He said, no, you people just shouldn't be taking this thing as it is. No. I think people can. We will have the money. We will have the money. And we were all like, oh, this man doesn't know the Gambia. People will promise you, and they wouldn't say you, right? But Dr. Jafari is so optimistic, and he just knows how to get people. Get them, and with the fundraising committee, they were able to do a breakfast whatsoever within no time, and people came and people donated. So we want to thank you, Dr. Jafari, for your optimism, and we want to thank you for this dream that you've brought, and today, of course, your name will go well down in the history of the book of the Gambia. I would want to proceed. We would want to call on the representative of the provost, Prof. Tinu, to please come and give his remark.
Representative of the Honorable Minister of the Higher Education, Research, Science and Tech, who is our direct boss in the university. Welcome, sir. And my Vice Chancellor. Thank you so much. It's nice to see you here. The Chairman of the LOC and his team, well done. Dr. Niya Adeajayi, the keynote speaker, I believe is an alumnus of the University of Ibadan. Yes? Just like me. Great you are. All heads of departments, distinguished colleagues, esteemed guests, our dear students here, members of the press, and ladies and gentlemen. My name is Atinuke Agunloye, consultant radiologist. I'm going to deliver this speech on behalf of the acting provost of the School of Medicine and Allied Health Sciences, Professor Gabriel Olabiyi Ogun, who is unavoidably absent. I'll read his speech now, so this is not me anymore. Distinguished colleagues, esteemed guests, students, members of the press, ladies and gentlemen, it gives me an immense pleasure to welcome you all to this grand event, the Banjul International Surgical Scientific Conference 2023. It is indeed an honor to serve as a co-host of this conference that is bringing together experts from the Gambia and the sub-region to share their knowledge, experiences, and ideas in surgical and related fields. I added the related fields actually, because you know when they say surgery, everybody just thinks of OBGYN, general surgery, but just to remind us that we also have related fields without which surgeries will probably not go, like anesthesia and radiology. We have interventional radiology actually as a minimally invasive surgery, and I'm glad one of my bosses will be delivering a topic on that later. We have dental surgery. So apart from us sharing knowledge, this is also an opportunity for the public, general public, to also know what the entire surgical field entails. Back to the provost now. This conference will provide an excellent platform to discuss the latest advancements, techniques, and best practices in the field of surgery, and also for academic collaboration. With the fast-paced changes in medical technology, it is vital for surgeons to keep themselves updated and informed to deliver the best patient care. And this conference has been carefully curated and put together to showcase the most relevant and pressing issues that impact our patients. The sessions and speeches will provide a stimulating and interactive platform for sharing ideas, debating current trends, and learning from each other's experiences. I'm sure that this conference will inspire, enlighten, and motivate us all to strive for excellence in our respective fields. I would like to express our sincere gratitude to all the esteemed speakers, panelists, and experts who have joined us for the conference, especially those who have been involved in the outreaches so far. I would also like to extend a warm welcome to all the participants who have traveled from afar to attend this conference. I hope you're staying in our cities comfortable and you find our hospitality warm and welcoming. Okay, so this hurts my hands a bit. Finally, I wish you all a productive, engaging, and enjoyable conference. We look forward to hearing your contributions and ideas that will shape the future of surgical practice in the Gambia. End of the provost speech. Now, what he has not included is that the provost has personally paid for the registration and sponsored 30 medical students to attend this conference. He believes that early exposure of undergraduate and postgraduate students to conferences like this would agitate their minds to decide on which specialty they would like to do in future. And surgery and the surgical fields are one of those specialties. We also have Dr. Oluwashola, the head of the ORG medical training, who has sponsored 5 students, medical students, additional 5 students, who will be presenting their thesis at this conference. We know that for us as faculty, it's part of our mentorship to encourage our students to present at these conferences and give them feedback. Thank you so much, everybody, for listening, and I wish you all a very fruitful conference.
Gomez, the Chief Medical Director of Edward Francis Small Teaching Hospital, Dr. Ahmad Jafari, the Provost of the School of Medicine and Allied Health Sciences, represented by Professor Tino, Chairperson of the Local Organizing Committee, Dr. Abubakar Jah, Registrar of Medical and Dental Council, Dr. Kabir Cham, and our keynote speaker, Dr. Ni Adi Ajayi, is a consultant surgeon from the United Kingdom. Other surgeons that are also here. Eurolink representative, Dr. George Fauris, Professor Yusuf Sako from Senegal, representatives from Ministry of Health, student staff from the University of Gambia and Edward Francis Teaching Hospital, development partners represented here, WHO, UNFPA, and others, members of the press, invited distinguished guests, ladies and gentlemen, good morning to all of you and welcome to the Gambia. Thank you for attending the opening ceremony of the first Banjul International Surgical Scientific Conference on the theme development of minimally invasive surgery in resource-limited settings. Capacity building programs such as this conference that brings together experts on this highly specialized area are laudable initiatives to address some of the pressing challenges in the Gambia. It represents a significant milestone in our collective pursuit of knowledge and innovation to advance development in the health sector in the Gambia. It is therefore my pleasure and privilege to stand before you as we embark on this exciting journey of knowledge exchange. The Banjul International Surgical Scientific Conference is an event that is unique as it geared towards showcasing surgical procedures and exchange of up-to-date knowledge in all surgical disciplines. The event will benefit from experts from home and abroad and from all the units at the Edward Francis Small Teaching Hospital. In our midst, I understand we have surgeons from United Kingdom, Spain, Nigeria, Senegal, and of course our own Gambian surgeons. The event is organized and hosted by Edward Francis Small Teaching Hospital in partnership with the University of the Gambia Postgraduate Office of the Edward Francis Small Teaching Hospital. Let me take the opportunity to thank the Chief Medical Director for his leadership to make this a success. There is no doubt the health system in the Gambia is grappling with many challenges, and these challenges include significant capacity and resource challenges. Hence, the theme that is selected for this year's conference, development of minimally invasive surgery in resource-limited settings, is timely and relevant. There is a need to develop skills in rapidly evolving area of minimally invasive surgery in all the surgical fields. Ladies and gentlemen, for the past years, the Edward Francis Small Teaching Hospital and the University of Gambia have benefited significantly from visiting academics, visiting surgeons, professors, and other experts from different parts of the world who come and work here with our local experts to deliver training, both theory and practical, including surgical services and the application of new and emerging techniques. We believe that this annual conference will provide a platform for deeper exchanges of ideas, knowledge, and will provide a mechanism and a learning tool for our young surgeons and trainees. The next 2 days will mark the opportunity for presentation of research work, exchange of ideas, thought-provoking discussions, and forging new connections that have the potential to shape future collaboration with partners abroad. The theme of this conference also encapsulates the challenges and opportunities that we face in our rapidly changing world and resource-constrained environment. For the University of Gambia, this is an excellent initiative and partnership. This conference will specifically provide the platform not only to identify challenges, but to discuss solutions based on recent advances and cutting-edge techniques in the field of surgery. The annual conference is also unique and different in many ways. Let me give you some examples. We provide benefits focusing on the service provision by performing much-needed surgical procedures in Gambia, which is the outreach program you talked about and other speakers have mentioned. The outreach program is certainly very impactful, and as Dr. Jaha said, save us a lot of money because these are very expensive operations. Second, the transfer of skills to surgeons and trainees in the Gambia. It's a very useful platform for that. Also, academic exchange, sharing of experience among local and visiting academics, experts, and trainees. The well-functioning of the health sector in the Gambia, to support government and its initiatives, the private sector, and other stakeholders, including development partners. Ladies and gentlemen, research and knowledge exchange through regular conferences is not only crucial to inform teaching and learning, but it also ensures that state-of-the-art knowledge and surgical practices are also showcased, and also to engage stakeholders to support policy and development priorities in the health sector. From the University of the Gambia perspective, there are three things that are important. First, it's an opportunity for us to reflect on how to build a research and innovation culture in health. And this we can do in partnership with Edward Francis Small Teaching Hospital. It involves building a critical mass of researchers, surgeons, and experienced academics in surgery, and also developing a research environment as a university. Second, it's also a recognition that we need to build capacity, both human and institutional, to respond to the opportunities for research and innovation. The School of Medicine and Allied Health Sciences at the University of Gambia has trained over 350 doctors from its inception to date, comprising 290 Gambians and 60 other nationalities. But considerable challenges are posed by inadequate infrastructure and resource constraints which we continue to face. The University of the Gambia School of Medicine and Allied Health Sciences should therefore be repositioned to respond to the strategic goals of delivering a better healthcare service in the Gambia. And what we want to do also is to strengthen the capacity in research and innovation, which means training more Gambians to PhD level so that we can also have academics that are strong in various health specialties and subspecialties. The third thing is we need to build sustainable partnerships with like-minded institutions. And I'm delighted that there are many organizations that are represented in this conference. Our doors at the University of Gambia are open for more collaboration, not only with partners within the Gambia here, but in the sub-region and beyond. We therefore call all our partners, public sector, international development organization, NGOs, private sector, and others to support the University of Gambia and the Edward Francis Small Teaching Hospital in our capacity building quest and research efforts necessary for the transformation of the health sector in the Gambia. Let me take this opportunity to thank the local organizing committee led by Dr. Abubakar Jah for making this conference a reality. I think your team has demonstrated their commitment. It's not an easy task, by no means, especially if you have 2 months to work on. So I really want to take the opportunity to thank you and the team, of course, the leadership of the Chief Medical Director. To our esteemed keynote speakers and experts coming from different parts of the world, your expertise and research are obviously the bedrock upon which this conference is built on. We eagerly await your presentations, and we are confident that your insights will inspire us, will challenge us, and more importantly, it will broaden our perspective, the perspectives of surgeons, trainees, students to improve the healthcare sector in the Gambia. To our participants, students and trainees, we encourage you to embrace this opportunity to engage in lively discussion, ask thought-provoking questions, and seize the chance to connect with fellow researchers, surgeons, and practitioners. The connections you make here may lead to lifelong collaboration, friendships, and the sharing of knowledge that transcends borders and boundaries. Let me welcome all of you to this conference, the smiling coast of West Africa, the Gambia, and I strongly encourage you to explore and enjoy the Gambian hospitality, the unique sandy beaches, the local Gambian dishes, and interact with our people and experience the Gambian culture. I wish all of you a very successful conference, and I thank you for your kind attention. Thank you.
The high table, particularly the chief organizer, the representative of the provost, the representative of the, particularly the Honorable Minister who is virtually present, and also representing my minister who should have been here. We know that he is very, very, and I will repeat it again, very much in love with such an endeavor work that you people are doing here. He told me just early this morning that he's whisked to the executive meeting, and he would have loved to be here. But I know he's here in spirit. You particularly know that the Ministry of Higher Education, Research, Science and Technology, since its inception in 2007, has been very much into research. The Directorate of Research came into in 2014, and we have been grappling with many other issues, particularly the coordination of research, administration of research, and research management. The conference here only articulates, and it will represent the idea of having, research coordination. When I say coordination here is that when we discover that research in the Gambia is done in silos, the research in the Gambia is not properly coordinated, and in the administration side, the capacity is not properly built, and so many things were not in line. So the Directorate of Research came up with a national research policy which was validated in 2022. Now that we have to implement the policy. And in implementation of the policy, it also calls for coming up with a NARIF, National Research Ethic and Regulatory Framework. This framework requires putting up structures. When I say structures, is we don't want to see research done in silos. We want to have a proper coordination of research. So NARIF called for the importance of having a National Research Council, which, yes, we know there are other councils that existed, there are other committees that existed, but we want to have a national one. And a national one called for a proper coordination of research in the Gambia. I have no doubt that the conference that is being organized here calls for the gap that I have stated in the beginning, that is our doctors, our nurses will interface or will interact with experts that are here, and in doing so, they will learn the experiences that has been practiced, is practicing in all over the world. You have to agree with me that nowadays, today, the world is moving at a very fast pace, especially in technological transformation. And as my brother will say, we have to involve in the competition. Compete, compete, and compete. If you don't compete, competition will leave you behind. The Gambia, we cannot afford to see the Gambia left behind. Gambia must be on board. And that is why I am so elated from the start when the chair stated how this conference came about. It shows how commitment It shows the commitment that some Gambians, some citizens, particularly, I have to mention Dr. Ja, who has been thinking about this, has been working in the situation like this, and would love to bring this to the Gambia. And finally, he made so that the Gambia benefits from this capacity building. Dr. Ja, we as the ministry appreciate your effort and all the organizing team to seeing this conference fruitful. I did not only admire that, I can tell you that I've been following you in your health programs. Particularly my family, I don't even delay. We have a calendar where we sit down and listen to what Dr. Ja says to the nation. This is the types of people we want. And from the beginning I listened carefully, that we know there is a lot of altruism in this field. We are aware of that. But a type of Dr. Ja who will kind of impute or transfer those nationalist attitude to our young ones to copy also and die for their country. It's good to participate for your country. It's good to die for your country. You cannot, in one way, abandon your country and go. After a long time, you will always come back and find the same situation that you leave your country. So it's good to participate for your country and learn. The Ministry of Higher Education, Research, Science and Technology, as the institution responsible for human capacity development stuff, is always ready to throw their weight onto an organization or a body like this that is standing for capacity building of a nation. I am so happy and I am elated, and I wish that these kind of conferences are organized regularly so that experience outside there are shared. And as you learn this experience, you go down to the grassroots and implement the things that you've learned from an international bodies or international experience that you may rub yourself with. So, on behalf of my Minister of Higher Education, and on behalf of the entire senior management team of our ministry, I am thanking the organizers and thanking everybody that are standing for the capacity building of the Gambia. Thank you.
Members of the high table, physically present and those remote, members of the local organizing committee, dear friends and colleagues, some old friends I can see sitting in the audience from our previous visits, and the new colleagues and friends that we have made this mission. Members of the press, distinguished ladies and gentlemen, in the interest of time, please permit me to stand with due respect on existing protocols. It is a very great honor for me to give a keynote address at this first Banjul International Surgical Scientific Conference. Banjul has felt to me like a second home since I first visited in 2018. That visit was with the WACS conference, which was personally opened by His Excellency President Adamu Barrow. I'm very gratified that at occasions like that and at this meeting there's this high-level engagement, and all the way through to medical students. I think it bodes very well for the future of surgery in Banjul and in the Gambia as a whole. I'm addressing the question of minimal access surgery. I come at it as a pediatric surgeon, but the principles are very relevant to adult practice. And in terms of the things that I wish to discuss, the overview is as you can see there. Talking about minimal access surgery generally, then focusing a bit on pediatric laparoscopic and thoracoscopic surgery, a brief look at the state of the art, and then looking at resource-constrained environments and what the priorities should be and how the practices can be built up. I'll end with some technical aspects and then summary and some recommendations. Minimal access surgery encompasses all of those interventions that we use to achieve surgical objectives with as little trauma as possible arising from the access. As one of the members of the high table mentioned, there are a range of interventions. Professor Tuna, I think, talked about interventional radiology. So it's all of those techniques, which are thoracoscopic, laparoscopic, robotic, flexible endoscopy, percutaneous image-guided procedures that we refer to as minimal access surgery or minimal access interventions. The benefits include reduction in pain, more rapid recovery, and importantly, synchronous with the theme of this conference, reduced wound infection risk. For example, patient presenting with stones in the bile duct. The ultrasound is the picture on the left, confirms stones in the gallbladder. The patient has an MRCP which demonstrates bile duct stones, and those bile duct stones are very nicely envisaged on an ERCP, which allows a sphincterotomy to be carried out and the stones removed. At a subsequent sitting, the patient undergoes a laparoscopic cholecystectomy, and these different minimal access techniques ensure a safe and smooth outcome. Another example, a 13-year-old boy who presented to us with peritonitis. This abdominal CT scan, you can see the bladder anteriorly, the rectum posteriorly, and a large volume of pus in between. Ultrasound-guided drainage of this pus allows us to get rid of the sepsis. We put in a percutaneous central line to allow blood sampling and the delivery of antibiotics. It's discharged well, returns in a few weeks, and has a laparoscopic appendicectomy with an overnight stay. Previously, this would have been a laparotomy in the acute situation, making a sick patient even more sick and possibly risking mortality. So minimal access surgery and techniques in terms of the intervention, but also in terms of the way in which we think about reducing trauma to our patients. I talked just then about inserting a central line, and we all recognize as practitioners the importance of venous access for modern day surgery. The uses are as outlined there. And we know, particularly in the resource-constrained environment, that lack of timely venous access causes significant morbidity and mortality. In the UK in 2010, NICE, which is the Institute for Clinical Excellence, issued a guideline. They call it a guideline, it's actually an instruction. And within 12 months, pretty much every hospital across the country had built the capacity to insert ultrasound-guided lines by a number of clinicians, surgeons, anesthetists, radiologists, so as a cross-disciplinary effort, the result of which it is very, very rare to have patients where venous access cannot be safely established. Simulation, simulation, simulation. When new techniques are introduced, it is really important for us to practice them off patients. And this is an example of that. A mannequin, an ultrasound machine, a probe, which allows people to get familiar with the technique before getting onto the patient. This is what it looks like live. In the first picture, upper left, that is the ultrasound demonstrating the left internal jugular vein. The carotid artery is beside it. Picture number 2, you can watch with the ultrasound your needle coming through. Picture number 3, it is tenting the vein. And in picture number 4, we've punched through into the vein, and using a Seldinger technique, we can establish safe central venous access. Once learned, the procedure is very, very reproducible. This is my own personal series at the time when I was doing a lot of venous access. This is 1 year's worth of work, 215 patients. You can see that the median puncture was 1. The range was 1 to 3. But the median puncture is a single puncture to get into the vein, do the Seldinger technique, establish the venous access, and you can see the complication rates there. 3 children with what I term a significant bleed, 1 requiring blood transfusion, so 1% significant complication rate. I'll go on to some historical aspects of minimal access surgery. So although we think about it as a new thing, it's been going on for many, many years. You can see as far back as Hippocrates, 400 years BC. More recently, 1944, laparoscopic gynecological examinations were being carried out. But this was with very crude instrumentation, and the flexibility was very limited. The game changer was this gentleman called Kurt Sem, and some people refer to him as the father of modern day minimal access surgery, laparoscopic surgery. And the thing which allowed him to make progress was the Hopkins invention. He's a UK inventor, and he invented the fiber optic endoscope in 1954. So Sem came along and started to play with this. A lot of his work was in the laboratory of patients. In 66, he developed the prototype for what we still use today, which is the electronic carbon dioxide insufflator. And by the early 70s, he was routinely doing what he termed pelviscopy for a range of gynecological conditions. He was a real innovator, and if you're an innovator, sometimes that comes with trouble. His colleagues thought he was certifiably mad. And in fact, at one point, he was forced to take a brain MRI to prove to them that he did not have a brain lesion which was driving his madness. He persevered, and in 1980, September 1980, he carried out the first laparoscopic appendectomy. And that started to open the floodgates for what we recognize as laparoscopic surgery today. So if we think about it in terms of eras, 1970s, that was the diagnostic era, 1980s, specifically in 1985, the first laparoscopic cholecystectomy was done, and with that, general surgeons got really interested, and there was a lot of engagement. Pediatric pioneers turned up in the late 1980s, and in the 1990s, reconstructive interventions began, as well as proper fetal intervention. In the 2000s, we recognized some of the complications and started talking about shortening the learning curve. and recognizing that it's not just a surgeon, but an institutional learning curve. So anesthesia, nursing staff, really getting around and ensuring that these procedures were safe and reproducible. If I think about our own significant milestones at King's College Hospital, Professor Mark Davenport, one of my senior colleagues at King's College Hospital, carried out the first laparoscopic cholecystectomy in the United Kingdom, 1993. In 2003, when I was in the department as a senior registrar, we carried out the first laparoscopic appendicectomy. It committed us as senior residents, and then when I became a junior consultant there, to about an 18-month period of going in for the appendicectomies to set up the protocols, and then we've since handed that to our trainees, who would regularly carry out these procedures independently and safely. 2006, we participated in what was called the MARCH trial that was looking at laparoscopic hernia repair. And 2009, we formed a minimal access group, cross-disciplinary. And I really want to emphasize that that is really important, to have our anesthetic colleagues on board, to have our nursing colleagues on board, so that we move forward together and we co-develop the service. 2009, we won a grant and we went to visit a team in Colorado, led by Steve Rothenberg, and that gave us a lot of confidence. Again, we went as a team, with an anesthetist, with a senior nursing sister, and on our return, we felt more confident about taking on increasingly complex laparoscopic and eventually thoracoscopic surgery. This is what our graph looks like. So 2002, you can see that there was very little by way of proportion. And by the time we were going to Colorado, by the time we came back in 2009, about 20% of our procedures had a significant element of minimal access surgery. In my own personal practice now, that is of the order of 60%. This is what our setup looks like in theatre. We have the Olympus version of what's the Storz OR1, and the ergonomics, which is a really important component of minimal access surgery, are made a lot easier by having multiple screens. Everybody who is in the theatre can see what is going on, and we can get right angulation to ensure that we work as efficiently as possible. And this allows us to take on increasingly complex surgical procedures. At King's, we have just acquired our first robot, so we're in the process of thinking through what procedures may benefit and can safely be done on a robotic system. In 2008, we presented and subsequently published in 2009 the feasibility of doing complex neonatal minimal access surgery. This was a systematic review, and in the interest of time, I'll just go to the summary, which is that complex surgery, Ladd's procedure, bowel atresia, diaphragmatic hernia repair, and eventually at the more challenging end of the spectrum, esophageal atresia and tracheoesophageal fistula repair, are feasible to be done with certain caveats. Important in this systematic review, the outcomes for the Kasai procedure for biliary atresia did not match the outcomes for the open procedure. And there was a worldwide consensus at the time that for now, that procedure should continue to be done open rather than laparoscopic. So that as people set up their programs, it's important to look at the literature critically. There are some procedures where there's serious benefits, and we would really urge to try and move in the direction of doing them minimal access. Others we would consider unsafe and counsel people against doing them. And then there are some in the middle that require careful evaluation. Thank you. So for now, while at King's we have a large biliary atresia practice, we don't carry out that procedure laparoscopic. One of my colleagues is just about to commence coli sections. This is a child with a congenital diaphragmatic hernia, and this can be a challenging condition. Here you can see on the left side of the chest, a lot of bowel in the chest, pushing the mediastinum to the right. There can be a high mortality in the worst cases. We see a lot of diaphragmatic hernia disease, partly because of this gentleman, Professor Kypros Nicolaides, who runs a large fetal medicine practice. Excuse me. Kypros Nicolaides is an innovator and runs a large and very successful fetal medicine practice at King's College Hospital. And this is the new unit, which is beside the hospital. And they carry out a procedure which is termed the fetal procedure. So it's a fetal intervention to try and improve the mortality for babies like the one that I just showed you, who are at the worst end of the spectrum. What the procedure seeks to do is to put a scope through the mother's abdomen under local anesthetic. It's a flexible scope. Intubate the baby's mouth and then deploy a balloon into the trachea. The balloon is then inflated to allow the fluid which would normally come up from the lungs to build up and essentially blow up the lungs like a balloon. It's called the fetal. And this is what it looks like. So the flexible fetal scope is introduced. It goes into the trachea. The balloon is deployed, blows up, and the procedure normally done at about 26 weeks is reversed now by puncturing the balloon at about 34 weeks. And there's a lot of evidence to suggest significant improvement in the mortality of these babies as a result of this intervention. Again, it's another form of minimal access surgery, in this case for the fetus. Increasingly, as I said, we move to complex thoracoscopic and laparoscopic surgery. On the left is an infant. We did this at the age of about a year with a thoraco-abdominal duplication. If you are doing this open, this would include a major thoracotomy extending into a laparotomy to remove this cyst. But thoracoscopic and laparoscopic, we ended up with 5mm incisions, so small incisions with an excellent recovery. On the right of the screen is cysts from CPAM, cystic pulmonary adenomatoid malformation, and this would involve a lobectomy, a thoracoscopic lobectomy. This is what the setup looks like. The instrumentation helps the innovation, so like a rotating stapler and an energy device which allows us to go through vessels which are quite sizable, but doing so quite safely and efficiently. thinking about the gastrointestinal tract, a few months ago, I looked after a baby with a rectal atresia. Rectal atresia happens in a place which is quite awkward. A little bit too high to approach comfortably from the bottom, a bit too low to get to from the abdomen. And so we looked at different options for dealing with this baby. This is what the contrast enema looked like. So contrast up the bottom, and you can see where the atresia is. And with a stoma in place, we were able to put contrast also from the top. And you can see that there's an atresia, but not much gap. The gap is about 2 millimeters between. And so we looked at minimal access options for this. And the procedure, the intervention is called a magnemosis. So using magnets to fashion the anastomosis. And it looks something like this. So top left is what we've rigged up to deploy the magnets. To the right, you can see an endoscope at the top, an endoscope coming from the bottom. And then under direct endoscopic vision, we're able to perforate the membrane and pass a guide wire through the atretic membrane from the bottom end into the distal loop. And then using that deployment system that I showed you on the left upper, we deployed magnets top and bottom. The magnets come together, and after 5 days, they cut through and form the anastomosis for us. And she was discharged at second attempt, day 1 post-op. The magnets passed after day 5. We did a contrast study by day 10, and the anastomosis has been fashioned. And with the permission of her parents, I show you a picture. She's going to make a mention. Thank you. So, with that in mind, just briefly looking at resource-constrained priorities and methods for developing minimal access surgery services. It needs some key drivers that are clinicians. Look at the evidence, make a business case, get the managers involved, and get consensus about what should be happening. Select the patients carefully, particularly the early ones, and choose easy procedures to do. Always recognize that it is a means to an end and not an end in itself. The end is safe, successful, efficient surgery, and the conversion is not a failure. Establish protocols and learn from adverse incidents. And I want to talk briefly about, or say something about, LMIC contributions. Colleagues in Vietnam and other places considered LMIC have become world-class experts delivering minimal access surgery. So if we want to train somebody now for choledochal cyst excision, we send them to Vietnam. It's classed as an LMIC, but that is where they go because they've developed the expertise. And it is my expectation that as expertise develops in Banjul here, it will become a center where people are sent to train for the accumulated expertise. I talked about simulation. Basic and intermediate skills should be acquired of patients before we work with patients to try and develop hand-eye coordination, ergonomic skills, dissection skills, use of energy sources, and importantly, suturing skills. Over the years, we've developed a number of low-resource materials to facilitate training. So this is 2 gloves, one glove inside another glove filled with water, and the trainees have simple tasks to excise the top glove and suture. And we've demonstrated the improvement in their surgical skills, which are then translatable to the theater with this sort of skills. This is a generic skills lab. We have something which is more specific for teaching our trainees how to do hernias. It's similarly based, but they have to put a circumferential suture around this. And again, we have demonstrated that if they are consistent, within 10 attempts at this model, their skills are approaching those who are labeled experts. Planning, planning, planning. So for every procedure that we introduce, we draw, we brainstorm, we look at the theater layout. This is where all of these equipment should be. This is where the anesthetist should stand, the patient, the headers, the instrumentation, and so on. And we have that plastered in the theater so that everybody can refer to it and know exactly where they're meant to be and what they're meant to be doing. So this is our setup for laparoscopic inguinal hernia repair. This is our setup for an appendectomy. And if we're doing it the same way each time, we start to get a reproducible system. So our trainees come, we say, this is the way that we do laparoscopic appendectomy in this hospital. It works very well, and we only make significant changes if there's a really good evidence base for doing so. This is our setup for major abdominal surgery, fundoplications, LADS procedures, and so on. The bigger children, we go between the legs. The smaller ones, the legs are closed. In summary, what I've tried to demonstrate is that minimum access surgery has a long history. The 1980s, with the innovations of SEM and other pioneers, brought in technology which allowed us to accelerate and to do things much more safely. That it is feasible to gradually increase the technical complexity and do so slowly, steadily, and that well-resourced units can carry out really, really complex procedures. And it's important for LMIC surgeons to understand these, to undertake and to adapt the techniques for local use. I try to emphasize multidisciplinary working, support from hospital leadership to get the appropriate infrastructure and to have procedures and systems in place, and to emphasize also frugal innovation. In terms of recommendations, if I may make some recommendations, to identify those key clinical drivers. And there are some seniors who will be in the room supporting the process who will not necessarily be operating themselves. Simulation first, always. Select the patients carefully. Don't be afraid to convert. Always have strong protocols agreed across the multidisciplinary team for new procedures. Review results regularly and transparently and learn from adverse incidents. A high table, both physically present and remote. If I may use some words to describe what myself, the wider team from King's College Hospital and from the Evelina think about this group of Gambian surgeons that we've worked with over the years and the wider team, I would use words such as empathetic, extremely knowledgeable, courageous, very technically gifted. We very strongly feel that if this team, the wider team within the hospital, are supported, sirs, that they will establish minimal access surgery to a level that is compatible with any country in the world.